What's up, everybody? Dr. Rossi, shrinksandsneakers.com. So I seem to be getting a lot of questions from people about treatment, essentially what amounts to like treatment-resistant depression, or like I've tried this medication, tried that medication, nothing seems to be working. So I want to provide you guys with a little bit of an algorithm here as to how one might go about treating somebody who is, quote, treatment-resistant. So what does it mean when we say treatment-resistant depression? What does that even mean? Well, treatment-resistant depression means that the person has failed at least 2 trials of medication. And a trial consists of 2 parts. It consists of an adequate dose and an adequate amount of time on the medication. So this is someone who's failed a couple of medications already. Now, you may be asking yourself, at what point does this become useless? At what point would we say that maybe medication is not going to work and we're not going to have any benefit, and maybe there's more risk to continuing to try all these different types of medications and come up with more intense regimens to try to treat the depression when it's not necessarily having any effect? So that number seems to be 5 trials. So if a person has had 5 adequate trials and has had 0 benefit, then they're most likely not going to benefit from medication. Now, it's not a guarantee. I don't want people to feel like I'm saying it should be hopeless here, but you have to be realistic with your expectations about what you're going to get from psychopharmacology. So you have to change your mindset and shift your mindset. So other options do become available, though. If somebody is treatment resistant, what can we do? Well, one is electroconvulsive therapy. Best evidence, best efficacy of any treatment that we currently have. So if you're really treatment resistant, electroconvulsive therapy may be an option for you. For people who find themselves being less inclined to enjoy that type of treatment because it involves, anesthesia and seizure induction, you may opt for something like TMS, transcranial magnetic stimulation. I don't necessarily think that's as much a treatment-resistant treatment as ECT is, but it's a viable option if you haven't tried it, and it may be the thing that does help you. You don't know unless you give it a shot. Another option might be ketamine. We now have Spravato or S-ketamine, and there's also ketamine infusion clinics throughout the United States that could help you. Another option is what we call quote-unquote heroic doses of MAOIs. So that would be stuff like over 90 milligrams of tranylcypromine. So those are big doses, very kind of dangerous territory we're getting into here, because that can cause orthostasis, and you can sometimes have to treat somebody with abdominal binders and glucocortisone to prevent the orthostasis, but sometimes people have had success on heroic doses of MAOIs when they're treatment resistant. All right, so let's go through the stages of treatment resistance. So the first thing I would do, someone comes to me and says, hey, Dr. Rossi, I'm treatment resistant, nothing works, etc., etc. I would first evaluate, what medication they're currently on, and then I would look to optimize that medication first, right? Because I want to make sure, do we have an adequate dose? Have we been on it long enough? So I would want to optimize the dose of that medication and then continue that medication for 6 to 8 weeks and see where the person's at. Now, I know they may be suffering, and you might be saying, well, Dr. Rossi, why are you doing this? You got to change, blah, blah, blah. Not necessarily. I don't know. This person's coming to me for the first time. I want to try this first. I want to start with the basics before I start calling people treatment resistant, before we start getting into different, algorithms for how to go about treating those patients. Let's say that doesn't work. Let's say they fail this treatment and now they failed a stage 1 drug, right? They failed that first medication. Let's say it's sertraline. Okay, so we optimized sertraline, we got it up to 200 milligrams, they took it for 6 to 8 weeks, and they had absolutely no benefit. Now we're going to move to stage 2. So stage 2 would be someone who fails 2 different classes of medication. So we would switch the class of medication. Say if we use sertraline, which is an SSRI, we may use venlafaxine, let's say, for example, and that is an SNRI, a different class of medication. So we can now see whether or not the person does well on that medication. Now that's, again, adequate dose and adequate timing. So again, another 4 to 6 weeks or so of treatment on a new medication. Now let's say the person fails that. We got to move on to stage 3. So what would be the next step? The next step would be to try one of the older medications. I would probably start with a TCA, tricyclic antidepressant, like clomipramine possibly. But there's other options as well. And the thing about those medications is the side effect profile is a little bit more robust. So you got to watch for side effects. And for anybody 50 years and older or anyone with a pre-existing cardiac condition, you have to get an EKG because there's always risk for QTc prolongation. So you got to watch out for some of the pitfalls there, but a TCA may be a good option. And again, they have to stay on it for a long enough period of time, as well as get to an adequate dose. Let's say they fail that. Not doing very well here. We're on to stage 4. Now that they failed both an SSRI, an SNRI, a TCA, we might try a monoamine oxidase inhibitor. And I actually think the monoamine oxidase inhibitors might be the most effective antidepressants. But they come with a lot of side effects, and they come with a special dietary restriction that requires you to avoid tyramine containing foods, things like aged cheese and tap beer. So they have to avoid certain things, they have to follow some dietary restrictions, so it can be difficult for patients. But if you are truly treatment resistant and your depression is really causing significant problems, then that may be the only option at that point for you. So MAOIs, and again, same concept, adequate dose, adequate time. You failed the MAOI. Where do we go to next? Now we're starting to think, okay, we need to do something more drastic here, and this is where I think ECT fits in, electroconvulsive therapy. If somebody's failed all of those medication trials and we're all the way down to stage 5, at that point ECT is probably your best option. So you would offer the patient ECT, obtain informed consent, and hopefully go through at least 12 sessions of ECT 3 times a week. So we normally do a Monday, Wednesday, Friday schedule, and we would do 12 sessions as the initial starting point. And then we would talk about and decide whether or not continuing ECT would make sense in terms of doing what we call maintenance ECT, monthly or bi-weekly. It will really depend on the clinical course and how that person responds. So that would sort of be the stages of treatment resistance and where you would go as you're working down the algorithm for this treatment. So the last part I'll talk about, which I did not mention so far in that 5 stages of treatment there, you could potentially augment with other medications. And I've made plenty of videos about lithium and the benefits of lithium in terms of reduced suicidal ideation and completed suicides. So lithium may be a very good choice for these patients if they haven't tried that before. Another augmentation strategy that's popular is T3, or thyroid hormone. So supplementing somebody's thyroid hormone has been a strategy used for treatment of depression for a long time, and that also can be an option. Let's say those things aren't working, but you want to do more augmentation. Obviously, things like Zyprexa are available. Zyprexa or olanzapine, also known as olanzapine, is a medication that's a dopamine blocking medication, but does have some antidepressant properties as well. So you could try supplementing with a second generation dopamine blocking medication if you're not getting the full effect. And obviously, another strategy that I didn't talk about here, but that I've made other videos about, is the combination drugs, things like California Rocket Fuel, things like Well Off, which are combinations of 2 different antidepressant classes of medication, which also can sometimes help, but have not really been proven to be that much more beneficial than monotherapy in treatment-resistant cases. So I don't think those are necessarily what I would classify as treatment-resistant options. What I would really call those is augmentation strategies for people who have had a partial response or have had some benefit in terms of the medications that they were using and needed and had a few residual symptoms left over that could be targeted with a different class of medication. So that's where the combination therapies fit in.